stipend, whichever I got, I spent in learning computer and to learn to drive a vehicle, which has really helped me so much. Now I think I'm again, at another junction of my life where I have to learn a new thing about AI. And doctors can never be away from technology. Otherwise, we would be really backward. I think we have to keep ourselves updated. Nowadays, the demand is not only in the medicine update, it is also in the AI industries. So I'm very happy that Mrs. Anita and Shan had accepted for the same in spite of their busy schedule. We are really very grateful for their presence here. And so we'll start the program now, and over to the speakers without much delay. Mani, over to for introduction of the speakers.
Yeah, introduction of the speaker. First is about Dr. Nilofer Noori. She has completed MBBS from SRM Medical College, Hospital and Research Center. She has done MD Pharmacology from Government Keelpark Medical College, Chennai. She has done fellowship in diabetology in Apollo Medversity and Royal Liverpool Academy, Hyderabad. She worked as a drug safety physician for 2 years, and currently she's working as a regional medical advisor, adult vaccine, GSK Pharmaceuticals, and medical point of contact for Tamil Nadu and Kerala. She has been very much involved in research and activities with few publications with first prize for experimental pharmacology national level conference. We welcome you, ma'am, to speak on shingles vaccine.
Thank you so much. Thank you for your warm welcome. So I first of all, good afternoon to everyone. I would like to extend my warm greetings and thankfulness for giving me the session about sensitizing about a new vaccine and adult portfolio. So I hope it's interesting. So I hope I'm going to share my screen. Just can you please confirm if you can see my screen?
Yes, yeah. Okay. You just put a PPT, yeah, and slideshow mode.
Yes.
We request all the delegates to put their computers in the mute mode so that you can, when during the question hour, you can unmute yourself.
So first, I would like to start with a small introduction about why we need to vaccinate adults. So we all know it's been very established that pediatric population, they need a vaccination to protect themselves from many vaccine preventable diseases. But why as an adult or an aging population, they need vaccination. So that's why. So initially, I will do some context setting, and then I will talk about shingles as a disease and a newer vaccine for preventing shingles. So without a further delay, I would like to go ahead with the topic. So first is, why do we need it? A small background about our immune system over a period of our lifetime. So when we are an adult, if you see, our newborn system is very underdeveloped. So what happens? So it is functioning well, but it is not developed properly. So we need vaccination or other infections to develop our immunity to protect ourselves from different diseases. But as you see, when we are older, our immune system is also working fine, as well as we have got a very good immunity to fight diseases. So in our adulthood, we are immune to majority of the diseases. So as we age, what happens is that our immune system knows how to fight the disease, but what happens is our immune system, like any other system in the body, it starts to deteriorate. So scientists and researchers have identified this phenomena called as age-related immune decline, or so otherwise known as immunosenescence. So what it depends upon both genetic as well as environmental factor, our lifestyle, everything. So overall, it's overall factors that determine like how fast we will age or how fast there is this age-related immune decline will occur. So if you see what are the changes exactly is going to happen. See, if you consider about the, the function of our immune system, there is going to be decreased hematopoiesis, decreased B cells, decreased phagocytic activity. Basically, our body becomes less resistant to infections, or does not fight the infection properly. So apart from that, other factors of the other organs, like ability to, for the cilia lining to function properly, or our gut microbiome, which is gaining very much interest in the recent days, as well as our cardiac wall strength, everything, all the other systems, their decline also contributes to the immune system decline. So what happens now? So what they are saying, WHO has told that immunization beyond infancy is a global priority. Older adults above 50 years are, like account for more than 27% of the total population of India by 2036, which means that we are expecting a, raise in the aging population by 2036. So how well are we going to, age? Either we are going to age healthy, or we are going to just okay. So how well it's going to be age healthy, or we are going to go towards frailty. So what happens as we age, we have certain challenges, not only our health as well as our immunity. As I said, as a natural phenomenon, it's going to go down. Other than that, we are prone for many other chronic diseases which also predisposes us to many infections. So it will be a combined effect of decreasing our health. So this is what I was talking about. See, either when we age, either we can go in for a healthy aging, or we can go for frailty. So many external factors like vaccination, healthy eating, physical activity, all that contribute to maintaining our health throughout our life. This is our well known, as well as life course immunization. We are not talking about pediatric immunization. We are not talking about adult immunization. Life course immunization is a gaining interest of topic, which shows that throughout our lifetime we can be prevented by many vaccine preventable diseases. So as an individual, we should consider vaccine as a part of our healthy aging. So when we are talking about adult vaccination per se, for our vaccination for our aging population, we know in India it's very, very negligible. So what are the factors that are going to influence this kind of thing? So one is a lack of surveillance. So if you see, there is a lack of surveillance about vaccine preventable disease in an aging population, and we all know there is no national guidelines about how to vaccinate, when to vaccinate, do we have to really vaccinate adults, those kind of, and programs also. Then other than that, first thing is we are still in the phase of secondary prevention, which means we are taking treatment as a precedent over prevention. While I believe as a physician we should move towards primary physician, and vaccine is the first step to do that. And apart from that, the cost. So nobody it's a very cost sensitive topic, where we have to be willing to invest some money as in elderly, which is very less. Psychologically it is a problem. So talking about adult immunization schedule, this is the recognized schedule for population after 19 years. So flu, you have to take yearly 1 dose annually, and Tdap. Now TT has been mostly they are telling that it's better to take Tdap. Scientists consider it's a good alternative, and we have to take it every 10 years and 1 Tdap in each pregnancy. MMR 1 or 2 doses depending upon when we are born. If we were born after 1957 or later, it's better to take it as early as possible after 19 years. Then varicella zoster. So if you are born after 1980, it's better to take 2 doses or later, or you can take after 50 years 2 doses of later if we have not got the infection. And recombinant zoster vaccine, again above 50 years, for and given us 2 doses. HPV vaccine for 27 to 45 years, 2 or 3 doses. Still there is a confusion about which type of vaccine. Then PCV 1 dose, and again PCV, hepatitis B, meningococcal. These are all high risk vaccine. Other than our usual, this is our actual vaccine schedule for an adult that which we can practice.
Dr. Jalalu, can you put your
coming to our topic proper, shingles. So this is how it will navigate shingles as a disease impact, and what is the clinical data for RZV, and how we can. I'll tell you some practical points about vaccinating shingles. Okay, so first thing is shingles as a disease. If you talk about the taxonomy, it belongs to herpes viridae family, and subfamily it has 3 viruses: herpes simplex 1, 2, and varicella zoster virus. So if you talk about the structure, there is a spike spike protein, lipid envelope, DNA, nucleocapsid tegument. One thing I just want to reiterate here is the glycoprotein E, which is otherwise known as the spike protein, which is used as a antigen in our vaccine. That is a basic design of our vaccine, which in the varicella zoster virus, the spike protein is used. So when we contract this varicella zoster for the first time, we are going to get a primary infection. We all know that first primary infection with varicella zoster is chickenpox disease. We are going to get overall rashes, fever, and depending upon any complications. So that is it. So why it will take? It's a self-limiting disease. It can be people recover. Children recover with after 7 to 10 days. So while we are recovering from that disease, what happens is herpes. It's a neurophilic virus, which means it likes the nerves very, very much. So what happens while we are recovering, there are many unknown, unproven mechanisms of how it ends up in the nerve, but it goes and settles itself in the dorsal nerve root ganglion and in the dormant state. So what happens next? So as I told, when our immune system deteriorates as a part of our immunosenescence, as age is an independent risk factor. Apart from that, many other immunocompromising conditions, like if some patients are having cancer or they are taking immunosuppressants. So what happens when that cell-mediated immunity is going to come down? This virus takes its chance and follows the replicates and follows the nerve root and causes a rash, dermatomal rash. This, because it involves the nerve, it is a very, very painful condition, and there is inflammation of the nerve, which causes severe pain and burning sensation for the patient. This is otherwise known as zoster infection or shingles, and that is what is the reactivation of the shingles. So what they are saying, it's a risk. 1 in 3 people are at a risk of getting or reactivation of this virus if you have had a childhood illness of chickenpox in their lifetime. That is a risk, global risk that WHO has quoted. So what happens? See, if, as I've already told you, age itself is an independent risk factor, and immunocompromising conditions like diabetes, cancer, autoimmune diseases, transplant patients, HIV patients, those are all at a more risk of developing his herpes zoster secondary to chickenpox in their childhood. So they are these patients with herpes zoster incidence is predicted to increase in the presenting a global growing burden in patients with comorbidities. So what happens? So mostly, how does it affect? So usual 50% of the patient, more than 50% of the patient have thoracic dermatomal involvement, followed by lumbar. Next is cranial, and cervical dermatome is affected, and sacral also 4% will occur. Then what happens? See, I'm going to skip this slide because this I have already discussed. So this is what happens. So this graph explains the specific immunity to chickenpox or varicella zoster virus. So initially, when we get that disease, what happens is that our chickenpox, there we get a sharp immunity to protect against the chickenpox. Then after some time, when it tries to reactivate, our immune system is working fine, but also it is good. So this trying to reactivate is doing some good for us, because it will indirectly boost our immune response to that, and the threshold of the immunity is maintaining. But when our immune system starts to decline, or if the patient is immunocompromised due to other conditions, our immunity sharply declines, and this puts our patients us into reactivation of herpes zoster. So this is, as we know, in India, we don't have any disease registry. So actual burden of disease is not calculated. But this global data, it is also a meta-analysis of many data. Proper incidence is not known, but still we will take what we have. From that, we can see that there is incidence is 3 to 5 per 1,000 person years. And the risk of person getting a post-herpetic neuralgia, which is a complication of herpes zoster, is 5 to 30%. And in recent days, there is a reason, due to many other immunocompromising conditions, there is also a risk of recurrence of herpes zoster in few patients, like 1 to 6% of the patient, they do get recurrent herpes zoster. So this on the right is an OPD-based herpes zoster data of 27 meta-analysis of studies in India for the incidence of zoster. It shows that 15 to 81% of the person, they go to dermatological OPD for the complaint of zoster, and out of those patients, 10 to 50% they have the complication, and they have those patients mostly who are affected are mostly having comorbidities where the predisposing factors. So as you can see, as the age increases, all the lines in different countries indicate the incidence of zoster. As you can see, there is an increased incidence of zoster as the age increases. This is across many countries. Apart from that, there are many comorbidities that will predispose a person for reactivation of zoster, like diabetes, CKD, chronic kidney disease, cardiovascular disease, COPD, even physiological stress, physical trauma, even psychological stress is a higher risk factor, if you can see here. Then there is depression, asthma. So there are many factors that will influence or predispose a person for shingles disease. See, if you can see, although we know that immunocompromised conditions are at a more risk of having zoster, but the burden of disease is mostly in the immunocompetent persons with chronic stable diseases. They have the incidence more. So we should always consider that even presumably healthy patients are at a risk because they are at the aging population. So what is the impact? So as we all know, I mean, both acute and chronic conditions, zoster is a very painful condition. It's very difficult to satisfy a zoster patient for treatment of pain if the person has zoster as a disease. So what happens? We may all think, we are always, as a vaccine, for any vaccine, we are always thinking about what is the mortality, or you are always thinking about the life or death situation for the persons. We are always tuned to think, because as a vaccine, we feel that it should contribute something to our mortality, or it should save a person from death. So that is the reason we are vaccinating. But we should always also think that a disease, as some infections like zoster, can impact the quality of life. So quality of life, sometimes it's not white and black. There is also a gray area where we have to think, what is our quality of life? How healthy I am going to live in my lifetime? So if we can see, zoster influences it causes severe disability, I would say, or severe morbidity for patients once they have the disease, even in acute as well as chronic stages. So in acute, if you see, it affects your sleep, enjoyment, mood, and relationship with others. Most of them are elderly patients, so their social life is affected. Apart from that, physically, there is weight loss, reduced mobility, there's maybe social withdrawal. So overall, I would say that herpes zoster as a disease, it impacts the quality of life for the patients. So regardless, any infections can cause complications. So 30% of the patients can land up in post-herpetic neuralgia. That is the most common complication of zoster. Apart from that, 25% of the patients have herpes zoster ophthalmicus. So you can see they can have keratitis, uveitis, scleritis. And the recent school of thought where the viral infections predispose the patients, especially zoster, is linked to increased incidence of stroke and MI in certain patients post the infection. There is a 20% risk in first 2 months post the infection. So some paper, they are saying that vaccination could decrease this kind of incidence of MI and TIA or stroke in these patients. So up to 4% of the patients with herpes zoster, they go in for stroke or TIA. Apart from that, secondary infection, then but less than 1% can get encephalitis, aseptic meningitis, and so on. So why do we need a vaccination? First thing is definitely antivirals are the mode of treatment for the zoster disease once we contract it, but it is shown to work better if we start the antivirals within 72 hours. So most of the patients, they miss this window. Second, apart from that, we have to treat the patients for neuropathic pain, which is like tricyclic antidepressants, topical agents, opioids also. Once if they have started getting a complication of that, it is very, very difficult to control, and often they need multiple pain controlling drugs to be effective for that pain. So even after that, only 14% of the patients say that their treatment is satisfied for pain for post herpetic neuralgia. So this is the rate of herpes zoster and PHN, which means that the complication of zoster also, the chances of you or a person getting a complication post zoster also depends upon the age. Not only we are at a more risk of, reactivation of zoster as a disease. Once we get it, if older we are at a more chance of developing a complication out of this disease. So what are the other risk factors? Age we have seen, but apart from that, there are many studies that show that diabetes as a independent risk factor for PHN and zoster. So it works two way, that herpes zoster is more severe in patients with diabetes, and herpes zoster as a disease can worsen underlying diabetes. So it is bad, either way bad for the patient. Apart from that, as I've already told you, in the first 2 months, they are at a more risk for cerebrovascular accidents. There are many studies that show this association. So more stroke than MI, but they are at a more risk of stroke than MI, but still either way, both cerebrovascular accidents, they are at a more risk. So males are at a more risk, and if they have already had a CVD, then that predisposes the patients to get a second episode or so. And as we all know, that COPD patients on inhaled corticosteroids or no use of corticosteroids is also a risk, and oral corticosteroids is an obvious risk for those patients when we compare them with the non-COPD controls. And this is what I told you, that herpes zoster is associated with stroke when the patient is, male predisposition is there, and if they have a previous history of CVA. And we all know COVID-19 as a disease causes immunosuppression and immune dysregulation, I would say. So this spiked the incidence of herpes zoster diagnosis, and the risk of herpes zoster after COVID-19 hospitalization was 21% higher than other diseases. So this is a risk of zoster in corticosteroid patients. So there is a sustained risk if the patient is on, oral or inhaled corticosteroids for any treatment. So this is what I was telling. There are long-term complications of herpes zoster disease, and 20 to 30% increase in the risk and cerebrovascular diseases for over 13 years after single episode. So we'll come to the topic proper, talk about the prevention. We all know what are the risk factors. Till now we know, we have, I've gone through what are the risk factors and why do we need to prevent this disease for our patients. So this is the actual design of the vaccine. This vaccine is a non-live recombinant zoster vaccine, where initially it has two components. One is antigen, other one is an adjuvant. Antigen is initially in the first slide I have discussed that it is taken from the spike protein of the varicella zoster. It is known to induce a varicella specific antigenicity if it is contracted in the body. So that's why it is highly antigenic. That's why it's chosen for the vaccine. Apart from that, we need an adjuvant system. We all know that I have already discussed that we are going to vaccinate patients whose immune system is declining, or immunocompromised patients who need protection from this disease. So just remember that adjuvant system is like an immune booster. So here it is used is ASO1B, which boosts the immunity for antigen. We combine this in this vaccine, and it's a recombinant zoster vaccine. So what happens is, if we give an adjuvanted formulation, that's what I told you, it's like an immune booster. So it causes a stronger, broader immune response, as well as it's a longer immune response. So the immune effect is sustained for few years. So obviously we tested our vaccine. This is a core clinical data for our vaccine. zoster, recombinant zoster vaccine. There were two major trials, which had 16,000 participants, 16,000 participants in Zoe 50, 14,000 participants approximately in Zoe 70. 50-70 indicates the age of the patient that were the cohort population used in the study, were in the study. So more than 50 years is Zoe 50, more than 70 years is Zoe 70. So both the trials had similar, study design. First is the objective of both the trials were to see the herpes zoster efficacy in person. The end point of this is herpes zoster occurring in that patient was the study end point of this patients. So the dosing schedule was 2 doses, 0 and 2 months. And apart from that, we wanted to analyze that for post-vaccination, if any of our patients get the disease, what will be their protection against the complications. So these were all the study design or the objectives of the study, both the studies. So in this study, we followed them for 3.2 years and found out that in more than 50 years, vaccine efficacy was 97%, and in more than 70 years, the vaccine efficacy was 91.3%. Below, you can see a tabular column where those are the actual number of cases in each group, like in vaccine group and the control group, which is a placebo group. So you can see that the number, how there is significantly reduced. As well as we also came to know that there are some patients, it's not 100% effective. So there are few patients who got zoster post-vaccination also. So what was their fate of those persons? So we came to know, we followed through them and saw that there was 91% efficacy in protecting against 91% efficacy in above 50 years and 88% efficacy in above 70 years for protecting against a major complication like post-herpetic neuralgia. And if you see on the other side, it was more than 90% efficacy in protecting against other complications of herpes zoster. Also, if you see that, if you think apart, by preventing shingles itself, we are reducing the risk with recombinant zoster vaccine of risk of putting a patient through a complication or risking a complication. So we understood up to 3 years the efficacy is good, but we wanted to test how long this efficacy is going to last. So as of now, we have 10 years evidence. So these patients from the start of Zoe 50-70 till 10 years, up to 10 years, this was an interim analysis. So up to 10 years data, we show that it was 89% efficacy was sustained against shingles disease in these patients. So for any vaccination, adverse event is a main key driver for the vaccinations. 1 minute. So we had two local and systemic adverse events post-vaccination. In local, more than pain, redness and swelling were the most common side effects, immediate side effects after vaccination, and fatigue, headache, myalgia and fever were the second most common, and the median time when the patient might suffer from these adverse effects were 2 to 3 days maximum, that too grade 3. And apart from that, there were no increased incidence of serious adverse events or fatal serious adverse events. Since it's an adjuvated vaccine, there may be a concern for potential immune-mediated diseases. Then there was no increased incidence from the placebo group to the vaccinated group. So the incidence was almost similar. So we might think, so these patients who were enrolled in the study also had some comorbidities. So as you can see, those persons had hypertension, osteoarthritis, dyslipidemia, diabetes, psoriatic arthritis, depression. So there are many complications, stable diseases where a part of the persons who had stable diseases were a part of the study. So we might think how this can influence the efficacy of those patients. So of the vaccine. So you can see across, I can see that from 85 to 90% is the efficacy for patients, almost similar, similar efficacy with the immunocompetent patients in patients with comorbidities as well. So what are the approvals and recommendations for the vaccines? So we have more than 50 approvals and 24 national recommendations for those countries who has a part of adult vaccination as a part of their national schedule. So recombinant zoster vaccine is a part of national recommendations in 24 countries, and CDC is recommending this recombinant zoster vaccine for above 50 years and above, and even irrespective of the persons who have got zoster or who have taken the prior varicella vaccine. So this is the recommended vaccine, and also especially it is recommending for other comorbid conditions with chronic medical conditions should receive RZV, and asthma patients with chronic COPD should receive it. So apart from this, specific to diabetes, ADA has recommended for all patients of diabetes more than 50 years. RSSDI India in 2019, they have recommended a recombinant zoster vaccine for all the diabetic patients above 50 years. So GOLD, which is a COPD guideline, they are saying that along with other vaccines, shingles vaccine should also be considered and used for those patients. So this is for the autoimmune diseases where the incidence of zoster is high. You can see for RA, there is a recommendation SLE, IBD, psoriasis patients, multiple sclerosis patients, and American College of Rheumatology. They also recommend herpes zoster vaccine for all the rheumatological diseases. Then again, for cancer patients, importantly, renal transplant patients who are on transplant immunosuppressants, HIV patients, and multiple myeloma, specifically European Myeloma Network has recommended RZV for vaccination. So this is a vaccine for zoster in National Psoriatic Foundation US has recommended this vaccine for patients who are going to be treated with immunosuppressants. So what is the schedule? So it is a 2-dose. You can see that 0 is the first dose and second dose can be given after 2 months later. So this has quite a flexibility. If we miss to give in 2 months, second dose can be given anytime between 2 to 6 months. The immunogenicity is not going to be compromised, or the efficacy is not to be compromised if the second dose is given within 6 months. Then it has 2 vials. So one is an antigen, another one is an adjuvant. Adjuvant comes in a liquid form, antigen comes in a powder form. We will have to reconstitute and give it as an intramuscular injection. So 2 doses, 2 vials, and it's an intramuscular injection. The storing is like other usual storing, 2 to 8 degrees. So if we reconstitute the vaccine, it is stable up to 6 hours. And we should never freeze the vaccine. It should not be freezed. Once frozen, it should be discarded. Next is it can be co-administered without any safety issue or immunological interference with flu, pneumococcal, and Tdap. So this is my last slide. You can see just a summary. 1 in 3 people will develop shingles. It's a risk, are at a risk of developing shingles in their lifetime. So as we know, it's a least morbid disease, but herpes zoster affects the quality of life of the patient, and it has more than 90% efficacy for patients above 50 years and 10 years long efficacy for up to 85 to 89% efficacy. The 10 years long data is there, and it is established safety profile is there. So this is just a minute. I think that's the end of my slide. So
thank you so much, ma'am. It was very informative.
I'm sorry, you're talking at mute, I think.
No. Can you hear me now?
I can't hear you, ma'am.
Yes, ma'am, we can hear, ma'am. We can hear.
Yeah. No, I'm just saying that as a pediatrician, I used to be worried about chickenpox. But actually, we did not know that so much of complications is there with the chickenpox after the herpes zoster. So, thank you so much. So, can I have any questions? Is there?
Can you hear me? I'm sorry.
Yeah. We can hear you,
but I can't hear you. Is it the same for everyone?
No, we can hear, ma'am. We can hear. Yeah.
But I can't hear.
We can hear you also.
Just a minute. Let me check my.
Ma'am, only my thing you cannot hear, but otherwise I think you can hear.
Let me just give me a moment. I will maybe leave and join back. Just give me a second, maybe because I can't hear anyone talking. Huh? Just give me a second.
No problem. You can proceed with the other talk, and the questions we can take it up later, I think, Dr. Mani.
Sure, ma'am.
So please introduce
Okay.
the next speakers. Yeah.
Yeah, I think it was an excellent talk. And coming to the next week, it's the most interesting topic on AI. First, I want to introduce Shan Balasubramaniam. He's a product consultant for higher education and training. He was in academia for more than 23 years in computer science department at BITS Pilani and NIT Warangal. He was the Dean of Academic and Dean of Work Integrated Learning Program at BITS Pilani. He has also spent 4 years in the software industry in the US. He has about 25 referred publications and 4 US patents. His research interests include data mining information and information retrieval, cloud computing, and systems for big data and machine learning. He has master's in computer science from NIT Warangal and a second master's degree from Indiana University, Bloomington, USA. Welcome you, sir. I think next is Anita Ramachandran, is an associate professor of computer science with work integrated learning program BITS Pilani, where she is also serving as the associate dean of academic programs. She has 14 years of industry experience across Motorola and Lucent Technologies and has worked extensively on broadband and wireless technologies. She did her BTech from NIT Calicut and master's from Illinois Institute of Technology, Chicago, and holds a PhD from BITS Pilani in the area of machine learning and geriatric healthcare. Her research interests include machine learning for healthcare, and she has around 15 publications and 3 patents. I welcome you, ma'am.
Thank you, Dr. Manigandan. Thanks, everyone.
Thank you so much, ma'am. Welcome both the speakers. Dr. Shan?
Yeah, I'll start.
Yeah.
Are my slides visible?
No, sir.
Sharing.
Dr. Nilofer, then there are 3 questions about the cost of the vaccine and when to give the vaccine post-herpes.
So, yes, ma'am. So, can I answer now or?
Yeah. I think sir is putting out share.
Okay. So, first question is the herpes zoster, post herpes zoster. There are few recommendations for that. One is that as per CDC, we can give the vaccine for the patient if their symptoms are away. So, once all the symptoms are gone, then we can vaccinate the patients. Then there are some other recommendations. They say we have to wait at least for 2 to 8 months. 2 to 3 months post the herpes acute zoster, and then we can vaccinate. So just to wait till all the symptoms are subsided and then we can vaccinate. So cost, I think if we are interested, we can put you, there are some special rates for doctors, I think. So it's around 8,000 per dose. So if you are interested, I can put you, in connection with the sales team.
Thank you.
Explain it better. Thank you.
Thank you so much. Over to the speakers. Dr. Shan, you can take over.
We can make it as a slideshow, sir.
Slideshow mode.
Yeah, I will. Good afternoon, everyone. Thank you, Professor Manikandan, Dr. Manikandan, and all the IMA organizers for inviting us to give this talk. Professor Anita and I are actually working on a research segment where we are looking at how to customize, deploy machine learning in healthcare context in general, particularly clinics. And this came at a juncture, the talk came at a juncture, and the discussions with IMA came at a juncture where we were also eager to get some early requirements understanding from actual physicians and nurses and anybody working in a clinic. So to that extent, we are also looking forward to the question and answer session to understand AI requirements, because that's a big deal. AI can do a lot of things in the lab, but when we actually have to deploy, there are conditions, there are issues. So it's important for us to understand what it means for you and what are the issues you are likely to face. How would it help, or how do you think it would harm? And so having said that, Professor Anita and I will kind of interleave these slides in the sense that this talk in the sense that I'll talk for with the first few slides, and then ask Professor Anita to take over, and then We will kind of go back and forth in between. Of course, we will be available to answer any questions at the end. Both of us will be available for that. Professor Anita, unless you have anything to say,
that's fine.
we can go ahead and start.
Yes.
Okay. Basically, this talk is a very broad sketch. There's a lot of AI happening, particularly in healthcare. Most of it is in the research domain, academics and medical researchers using AI or applying AI or even inventing AI for the purpose of application in healthcare. Most of this is happening in the laboratory setting. But there are quite a few commercial applications as well now, including some in India, which are getting deployed in hospitals. And the research is slowly being transformed to be positioned in hospitals and clinics. Although the bigger hospitals, sorry, is there a question?
Request everybody to mute themselves, please.
Yeah. So the penetration in India is not deep today, but it is likely that AI deployments will happen in clinics. While the bigger hospitals will take the lead, I think it's going to be impactful even in clinics, and as the awareness increases, the impact is probably higher in clinics because the need would be higher according to our estimate. But this is not a quantitative estimate as of now. Qualitatively, we are predicting that in smaller clinics, the impact is likely to be higher. Having said that, while the use of AI is very broad and there are a lot of applications, we are restricting our focus to discuss use cases that is where AI can be deployed in the context of clinics, particularly in clinics in rural India and small town India, Mofasal clinics. The reason for that is these are the places where the number of physicians is not many. The number of healthcare professionals in a clinic is not many. There is focus to the application of AI, and therefore we are looking at this context. And today's discussion is going to be focused on this context, although some of this will obviously be applicable to larger hospitals as well. So this is broadly the agenda for the talk. We're going to talk about what is possible with AI. This is just one slide because a lot of things are possible and we cannot demonstrate possibly everything. And this is only meant to be a teaser in case you have not thought about it or in case you have not looked up what is AI doing or where is AI being applied. So we're just highlighting that. And subsequently, we'll be talking about what is actually being used in hospitals today. Actual products being deployed and used by healthcare professionals. We'll talk about that in multiple slides, across multiple slides. Both products available abroad and used abroad, as well as products made in India and used in India. And then we'll talk about state of the art. Where does AI stand today, both in terms of research and commercial products? Then we are hoping towards the end that we will have discussion that our understanding is improved in terms of what is it physicians are looking at. And hopefully there will be questions that you will ask us to elaborate the discussion and set the context. So we have mentioned a couple of points for discussion. One of them is data collection and availability. Data is patient data here, treatment data, and so on. And what are the concerns of healthcare professionals in using AI? From your perspective, what is it? And then what are the objectives of the AI community in general, along with the healthcare community? In 2 to 3 years, what is it the healthcare community would like to achieve in terms of AI? How much of that is feasible for the AI community to deliver? While the physicians or the healthcare community may have a long wish list, AI community may not be able to deliver on those. So we are talking about next 2 to 3 years. What is it that healthcare professionals want and what is it that the AI community can deliver? We'll also briefly talk about ancillary systems where AI may be applied, although that is not directly relevant to today's talk, or not directly impacting on today's talk, but there'll be deployments in senior homes. Insurance companies will take into account how AI is playing a role. They will apply AI, for instance, to predict someone's life. They could use data to predict someone's life period and so on. And community health is a big thing for AI applications. In the era of COVID, this was deployed heavily to predict not only the diffusion rates and so on, but also, what are the treatments, how long COVID is affecting people. All of these are community health issues. And this is one area where AI is getting deployed heavily. Again, that is not directly related to what we are talking today. We are restricting our talk to what is feasible and what can we do in clinics. Yeah, that's the agenda. So as I said, I'll start briefly with the skyline, and along when we start talking about reality, I will transition to Professor Anita. So when I say skyline, I'm actually asking what is possible with AI in the near future. What is in the horizon? In the lab setting, there are a lot of things happening. In research and clinical trials, a lot of things are happening, but we are also talking about what is possible in the clinical setting. That's the leftmost column. And then we are briefly talking about community health. And there are also applications in back office automation, which is probably where software has been playing a role significantly already. How the back office of a clinic can be automated. There also AI can help, but that's not going to be as impactful as what is on the other side. The clinical setting is what we are talking about today. But in the lab setting, that will come through what is happening in AI in lab setting will come through AI-enabled equipment. Research and clinical trials are happening all over the world today using AI, multiple scenarios, and we'll talk about some of them as well. So in the clinical setting, what we are seeing is that AI assistants are likely to play a role in clinics. How will they play a role? One is they can automatically summarize case details for physicians. So obviously there is, whenever a new technology comes in, there's always a fear or hypothesis saying that, will it replace the human being? I don't think that is ever the purpose or that is going to happen as well. Human beings are general purpose intelligences, and it's not going to be likely that an artificial intelligence will replace them, particularly in the healthcare context. But what do we see is that AI assistants can improve the productivity or increase the productivity of physicians and nurses and lab technicians and so on. One of the places where they can help is automatically summarize case details, extract information from patient records, lab or imaging reports. This can be historical or this can be immediate tests. Also enable doctors in faster and accurate diagnosis and treatment options. One of the things doctors have to typically do is consider, quite a lot of options, particularly when new patient comes in. While they come in with symptoms, unless the doctor looks at historical record, what is the patient's health history, what treatments have they undergone, what is their social context, what is their economical context, where are they working, their workplace environment, all of these details affect the condition of the patient. So there's fair amount of information for a doctor to take in. Quite often in the Indian context, doctors may not have the time and the energy to go through all this information in the first sitting with the patient. So this is where AI can do this offline. If the information is available, AI can summarize this, enable doctors to focus on a quick diagnosis and the treatment option. So this is what we are saying is in the clinical setting, these things are feasible with AI assistance in the next 2 to 3 years. In the lab setting, what can be feasible in the next few years is that already lab equipment are getting enabled with AI. So there will be improved tests, scans, and visualization of scans and tests, which is likely to come with AI. It's also possible to correlate with other patients' results which is done automatically. Today, it has to be done by the doctor. They have to look at their case histories, and they have to look at the collection of data available with them. For instance, if you do a CT scan for a particular kind of disease, and you may have in your experience seen similar things. For instance, you want to decide whether there's a tumor or not, but a machine can do this automatically and quickly. You don't have to compare a lot of scans for you to think about it. While this will improve your productivity, this is not going to replace and come out with an answer, quick answer of whether there's a tumor or not. That's not the purpose of it, but just the comparison time can be reduced, particularly when you have large amounts of data. That is when AI is useful as well. And that's a useful case in practice as well, because if you have a large number of scans to think of, then for a human being to look at all of them and compare them is going to take time. Then in research and clinical trials, as I said, a lot of things have already been happening, but more and more AI is getting deployed in these activities. Participant recruitment in clinical trials is being automated with a lot of AI involvement in this. And identifying recurring patterns of diseases, AI is being used and is likely to be deployed within the next 2 to 3 years extensively. Outlier analysis is a situation where you have diseases, but there are outliers with symptoms, or outliers with similar symptoms, or outliers with different symptoms but having the same disease, and so on. This is since the numbers of outliers are likely to be slow, the researchers for a particular disease may tend to ignore them because they cannot afford to look at every outlier separately. But this is where the machine learning aspect or the AI aspect can pinpoint where are these outliers positioned in this whole picture, and what is matching with the disease's symptoms versus what is not matching with disease's symptom, and so on. Anomaly detection is similar to outlier analysis. In this case, we are not talking about outlier patients, but anomalies in the system. You're testing a patient's body for a lot of information. There are anomalies in the test results, and detecting those anomalies based on data is something AI is being doing well in general, and is getting applied in healthcare. And in the near future, you're likely to see that impact as well. Correlation analysis and prediction or prognosis before a patient comes to visit the doctor. This is likely to happen in case where people are prone to specific diseases or specific conditions, and but they can't keep going. They don't often. They may neglect and not go to the doctor periodically. Whereas if they have a wearable, or if they have some mechanism to test themselves, the prediction and the prognosis can happen automatically. And treatment prescription as well, when there are alternative treatments, AI can help the physicians in weighing the consequences and help the physician choosing what is the right treatment. I briefly talked about community health, and I think this is something most of you are probably familiar with, that a lot of statistical analysis was done and very helpful in the context of COVID. So this is likely to take off with other diseases as well. I will not talk much about back office automation, although this is something that can be deployed readily today. Scheduling of appointments, logistics in terms of, for instance, procurement of pharma. How do you predict that, seasonal, for instance, seasonally you want to increase your flu vaccine purchases or not? So those kind of logistics, this is something AI can do routinely. A patient engagement, how do you want to engage patients outside your clinic? There also AI can come in and play a role. Okay, this is basically setting the overall context and saying these are all the feasible things in the next few years. I'm not talking about 10 years, 20 years down the line. All of what is in this slide can happen within, or likely to happen within, the next 2 to 3 years. Now, given that picture is a rosy picture. What will happen and what will be the impact? What will be the consequences, positive and negative? that a lot of that has to be discussed. And as we start deploying AI, we will also see consequences, both positive and negative. Some of those consequences may be very good, that physicians like you would want to deploy more and more AI or expand the scale and so on. And some of those consequences could be negative, and you may want to say, roll it back or be cautious about this. Therefore, it's important to ask what is actually being done today. What is actually being deployed today in hospitals? So this slide kind of quickly points out certain things. One is intelligent diagnostic equipment. All equipment manufacturers, including high-end manufacturers like those who make CT scan equipment or MRI equipment and so on, to low-end, not really healthcare products such as watches that measure your BP and so on. Everybody is including AI in their equipment. This is kind of in a way slightly different and significant from deployment of AI in clinics, because this AI is hidden. It's not visible to physicians or patients, although patients may be wearing these devices or physicians may be using these devices to test patients. This is not visible that AI is part of this. So therefore, the use of this will have implications which are different from other uses. But this is something that is becoming realistic today. Intelligent diagnostic equipment, already there are devices out there, like including scanners, for instance, CT scanners, which have diagnostic equipment internally built in to refine the scans, which earlier probably a technician would have to adjust the resolution, change the angle and things like that, which is being done internally by the AI today. And then there are clinical decision support systems where doctors are being assisted by decision support systems, or that is AI assistants, in making clinical decisions, which is determining a disease, diagnosing a disease, choosing a treatment and so on. And then there is predictive intelligence for detection and diagnosis, where the AI assistant is helping the physician in consultation, that is in real time, when the patient goes to the doctor. So the doctor is using AI in the backend, talking to the AI and identifying the disease, and then coming up with the diagnosis. Some of these are obvious and very common examples, like radiology interpretation, which is probably one of the early success stories in the last decade, that is between 2010 and 2020. Radiology, use of AI in radiology was the single most significant success case for AI. Use of machine learning in the case of radiology interpretation, where now the significance of radiologists in the loop has decreased because of use of AI. In most cases, the AI or machine learning can automatically pinpoint scenarios and conditions. So this is kind of the very low-hanging fruit, that this is already getting deployed in many places. And other minor things like personalizing and alerting patients to conditions and events. This is again simple. AI is getting involved here. Then prescriptive recommendations of physicians. So while physicians normally prescribe the medicines and treatments, AI can come in and then kind of weigh the treatments recommended, can kind of choose or provide alternatives, provide options for treatments, and say which is likely to be more successful and which is likely to be less successful, or which is likely to produce more side effects and things like that. So why do we need AI for that? It is only a matter of increasing the productivity. While physicians routinely do this, you can reduce the effort and therefore increase the volume of prescriptions, volume in terms of number of people to whom you're consulting, diagnosing, and doing prescriptions. That number can be increased for a fixed period of time, over a fixed period of time, by using AI. Long-term health monitoring, where a patient uses wearable devices or keeps other form of records, and AI can monitor those conditions. This is particularly helpful for elderly patients where there are a lot of medication taken, there are a lot of tests that you go through. It's often possible and it happens that the patients ignore these things because these are becoming routine and burdensome for the patient. So the AI can monitor the health automatically and predict that some situation is likely to occur or prompt the patient for a doctor's visit, or in turn, complementarily prompt the doctor to saying that this particular patient's condition is deteriorating. Even though the patient may be outpatient, that is possible for the AI to alert the doctor. So obviously, this is useful in geriatrics where patients are confined to a hospital or to a senior home and so on. Then there are health support systems. Again, I will not talk much about it, but these are hospital administration things that is improving the routine matters for hospital administrators, whether they are nurses, whether they are admins who are involved in welcoming the patients, receiving the fees and things like that. Plus community healthcare, which is what I talked about. This is community healthcare. While a lot of things are happening in research, this is also happening in the case of deployments by government. Keep track of epidemics, endemics, and pandemics like COVID. I'll pause here and Professor Anita, do you want to take over at this point, or do you want me to go through the research as well?
I can take, I mean, we can.
Okay, go ahead. Please take over then. Maybe I paused it because maybe this is the right time in case people have quick questions, clarifications of what we are talking about, or there are comments. Then we can take over starting with this.
There are some use cases that Dr. Arulavan has put up in the chat.
Okay.
I think he's just adding on to what we are trying to say.
But
So
it may be worth reading out so that people have.
So one of the use cases is converting text to voice. So the reverse is there, voice to text is there for creating case files when during the consultation, the dialogues that doctors have with patients, right? So the speech to text is there, which also has inbuilt AI, which is again, like Professor Shan said, may not be visible explicitly to the user, but it's there inside that can convert speech to text. And another use case is mentioning is why a particular disease occurred in a certain scenario, right? How do you root cause? What are the conditions that led to a particular disease? Automatic prescription generation. So these are actually areas where there are some availability of products, but then there's also research happening side by side.
புடவை எடுத்துன்னு பொன்னிக்கு 60 நினைச்சிட்டா போல இருக்கு 59 முடி வரைக்கும் தான் பூஜை வைக்கிறா அது சொன்னதுக்கு நான் என்ன சொன்னேன் அண்ணன் உங்ககிட்டயே கொடுத்துருமா புடவை எடுத்துன்னு போயிடுங்க எது கொடுக்குறதா இருந்தாலும் அண்ணன் கிட்ட
Okay.
Sorry for the disturbance. I think there's a lot of cross.
Yeah, okay, that's fine. So we can take this. If there are any other questions, we can take them now, or we can move on to the state of the art and research.
I think we can move on to the presentation. At the end, we can have now.
Okay. So in research, whether it's academic research or research in the corporate software world, there's a lot of significance given to diagnosis of clinical conditions. Almost every specialization in the medical field, be it pediatrics or obgyn, oncology, ophthalmology, geriatrics, whatever the specialization is, they're all ripe with AI research for diagnosis, right? And most of this research, as we understand, a lot of this is primarily in two areas. One is in the field of oncology, and the second one is the field of cardiology. So there are, in research, what they do is they develop machine learning models, which are trained on data sets that are available from clinics or hospitals. And they create models that can look at several features, which is basically symptoms or lab test reports, and then be able to diagnose a particular condition. There may be solutions available there, but the research continues in the research world, and they're always looking for how to increase the accuracy of diagnosis and how to do it with lesser features, or in other words, how to create machine learning models with lesser features, which means how can they do the same thing or achieve the same thing with lesser number of symptoms or lab tests, so the patients don't have to go through several tests, and how can they do it in lesser time, right? So that's one area that keeps getting a lot of focus, even though there may be models available for diagnosis. Clinical decision support systems, the pure software-based CDSS might have been there, but with AI, there is a possibility of stitching together patient's current conditions with his or her clinical history, his genetic information, and so on, and then try to identify and diagnose conditions, and also do predictive analytics, right? So to take it a notch further, predictive analytics is also taking a lot of focus in the research area, where AI is used to predict, like Professor Shan said, like used to predict the onset of certain conditions, like a stroke happening, or chronic conditions like diabetes, right? And then the next step is there is also this personalized medicines, which is called precision medicine, which is about giving personalized recommendations for individual patients. So if I'm reporting certain condition, I'm reporting certain symptoms, instead of applying a general machine learning model on my conditions and telling me something, the AI will take my specifics into consideration and give me personalized recommendations, right? Or help the doctor give me personalized recommendations. So diagnosis, and then personalized predictive analytics, personalized medicines, or precision medicine, these are all areas where a lot of research is happening. Another one is where the hospital administration part, where there's AI used to predict hospital workloads, cost management, and so on. Basically, it smoothens out the workflow management and the administrative activities. So AI sits inside a lot of this small things like speech-to-text conversion or image-to-text conversion, right? So in several hospitals, when we go, prescriptions are written by hand. But then when we exit the hospital, they say, can you scan the prescription? So that that gets uploaded in the form of digital record somewhere. So such electronic medical records, EMRs, right? That also may need to be converted to text, so it can be used to train machine learning models, or used for further processing. That's also a possibility with AI. Recognition of handwriting, right? What is written by hand by the doctors, that's another small AI application. So all this help doctors to build case files faster, right? So how can you get the patient, how can you reduce patients' waiting time? How can you manage patient records better, create and manage patient records better? These are small areas that research keeps happening, and there are also commercial products side by side. What has enhanced the whole healthcare scenario is the emergence of IoT also. We all must be knowing about these Fitbit watches and or wearable devices that can monitor the parameters, vital signs like heart rate, blood pressure, temperature, all the pulse and all that, right? So these devices also have small inbuilt AI capabilities that can help predict several conditions. So some of them, the more expensive ones, can predict the onset of stroke or some cardiac arrests. There are what are called hearables, which are like these earphones that you can, earbuds that you can put in your ears, and they can sense signals and make use of it to predict conditions like epilepsy. Right? So these are, some of them are prohibitively costly, but then the point is that AI is being applied in those kind of scenarios also. So the emergence of IoT, Internet of Things, has made things even more exciting. So now there are wearables and hearables and other small devices with sensors in them, which can monitor our parameters on a continuous basis. And this also enables us to do continuous monitoring of patients, or even need not be patients, but continuous monitoring of human beings, right? And that can generate data and help physicians to detect anomalies, not necessarily while the patient is reporting a condition, but it is possible for physicians to do offline analysis of this data and be able to predict that, okay, somebody is likely to show symptoms of a stroke or a cardiac arrest, right? Some of these research have been converted to commercial products, but the research continues because, as I said, the focus is to get to do things in a faster, easier, and more accurate way, right? So, Shan, can you go to the next slide?
Yeah.
And it should be in the other, what is that? The slideshow mode. Right. So in the commercial products or small applications, I mean, if you look at the Play Store on Android, you'll find small applications that can do something. Some of them may be AI enabled, some of them may be just softwares, but there are small applications that are healthcare applications that are on the phones available as apps on mobile devices. But otherwise, by and large, a classification that we thought was products in the diagnostic equipment side, products in clinical decision support systems, robotic systems, patient health management, precision medicine, and hospital administration. A lot of products. So that's just a list of an illustrative list. There's much more in that. Just to illustrate, Caption Health in the diagnostic equipment. Caption Health is a company that produces AI-enabled guidance for scanning and capturing images during the ultrasound scan. So it's not just enhancing a scan image, or it's not interpreting a scan image, which are also solutions that are there, but they've gone a step ahead and said that they will guide whoever is doing the scanning to help them to scan properly and capture images properly during the scanning process. Leica Biosystems has their pathology, digital workflow pathology management, right? So they use AI and image processing techniques in their pathology workflows and slide scanners and so on. There are more there. Clinical decision support systems, the Viz.ai, right? So they have some solutions in the neurology and the cardiology domains. And there's a company called Regard, which has products to diagnose patients using EMRs and electronic health records, EHRs. There's a company called Beacon Biosignals, which treat neurological and psychiatric diseases because it is able to analyze EEG signals. In the robotic systems, domain, we would have read about AI robotic-enabled surgeries, which was done. I think it made news a few months back. So there's companies like Accuray CyberKnife, which uses AI to treat tumors, cancerous tumors precisely. So it's not just it's not about treating the entire body, but doctors will be able to treat the affected areas instead of the whole body. So MicroSure, another company, is helping to create what are called motion stabilizer systems, which can improve precision during surgeries. Right, hospital administration. There's a lot of software. During COVID, we all migrated to this online consultation apps and the online ancillary systems like the pharmacies and delivery systems, and even pathology centers, where we could take appointments and they'll come home and collect samples and so on. Right. So there's several hospital administration software that can eliminate operational bottlenecks and improve the hospital workflow, and automate repetitive tasks and so on. Patient health management. These are like small applications that patients themselves may be able to use, like Hello Heart, for example, help people to manage hypertension and in general overall heart health. There's this app called Twin Health, which helps to manage diabetes. There's also in the domain of psychology, with this online AI application that can help counsel people and so on, right? precision medicine. So that's like the personalized medicines that we were talking about. Clearly, Dario Health, Twill, etc. So they have abilities with which they can diagnose and provide personalized treatment plans to people, or be able to chat with patients and then suggest a next step of action depending on what they're reporting. Right. So these are the kind of things that are there. The next couple of slides explain some of them in one line. Shan, if you go to the next slide. Yeah. So these are some examples of psychology, the Happify Health and ISO Digital Health, AI-driven cognitive behavioral therapy. These kind of things are there as commercial products, and they're used by hospitals. Several hospitals across the world. The next one is also a slide that explains, whatever was there in the summary slide, and in particular in India. In the next slide. Right, there are several, like I said, with COVID, we all got exposed to a lot of online scheduling apps and consultation apps. Doc Health is a product that does task management and workflow automation. Tonic for Health is focused on the patient's life cycle. So they take care of everything for the patient, from pre-registration and intake through check-in and payment. Visual DX is a clinical decision support system. So they have some smart searches for the symptoms that people are reporting, conditions, drug reactions, and so on. Isabel, they claim to be doing differential diagnosis, and it also has a self-triage and clinical educator piece of software, right? And there's iSensus, which is a continuous vital signs data monitoring system, which monitors BP, SpO2, ECG, and temperature. And it has a prediction platform that can predict if there's anything going to be wrong with those collected samples. Resolute is a company that makes that screens wherein doctors can write. It's like this Kindle screen. They can type your consultation notes and prescriptions and all that, and it'll convert into digital records and store them as electronic medical records. Next slide. Yeah. Tracker Wave is a real-time location services for smart hospitals that enables administrators and doctors to track the exact location of nurses and other healthcare staff in the hospitals, so that they can be called into a particular place, and messaging can be done easily. Dozy is a smart bed, I think, which supports contactless remote monitoring, patient monitoring, and early warning systems. And these are based on AI, so they have some sensors on the bed that can collect data and then do some analysis and predict conditions. Or the larger players, Microsoft, they have come up with some solutions using OpenAI and optical character recognition, which is again for converting the notes into images. Google has collaborations with Apollo Digital Health, not just for that product diabetes, which is by name itself for managing diabetes, or for diagnosing diabetes, but other things also. And EMR Studio is another software that does help in administration, like workflow management and building case sheets and so on. Right. So these are some of the things that are used in the country, in India. And like I said, along with these, while there are commercial products, along with these, research also keeps happening, so that the functionality is able to be done in a faster, easier, and more efficient manner. Right. So this is it's kind of the layout of the commercial products and the research across the intersection of AI and healthcare. I'll take a pause here. Do we have any questions?
There were a few questions posted in the chat, and we can defer until the end for them to be.
Okay.
or we can answer some of these now.
How to link social media with my own web page?
Yeah, that was one question. I think that has nothing really to do with AI. Today, there are people, I mean, this is okay. The younger generation is very adept at this. I'm 57 years old, so I'm not the right person to answer this question. But I can tell you, there's nothing to do with AI. Okay, today you catch hold of a college student, they will be able to tell you how to put up a web page for yourself, link your social media, embed something in, YouTube, embed something in Facebook. All of that is, you don't need to know. Somewhere a related question was, can I do it without coding? Yes, you don't need coding for this. All of this is doable readily. This is just a couple of buttons click. There's some cases where code is existing, code is available on the web, you have to cut and paste. But even that, as I said, if you catch some youngster, they'll be able to do it very easy.
So, if I may, I have one question, if it is
Yeah,
okay.
please.
So, yeah, all this were part of usual regular practice or physician in diagnosing and managing. Since I'm on the initial part of the drug development and things, so how it is going to affect the drug picking up lead or selecting or in the drug development process? Is there been any already
Yeah,
there's been a success
there's
or how does it?
there's plenty of research in drug development, and except that that is not something which is going to get deployed at our level. So it's only the larger companies that are going to control the use of AI in drug development. So there are a lot of products as well as research as well as products that have come out. One of the things, okay, I'll highlight this in very brief phrases. One of this is there are a lot of permutations, combinations you have to test if you're doing drug development. That's the reality today. And that is significantly easy to achieve by computerization, where you can test out the permutations, combinations synthetically or digitally. And AI helps in the case of exploring those permutation combinations, even reducing the number of permutations combinations to be tested. The classical process, computerized process is, in some cases for drugs, you have to test 1,000,000 combinations. AI can reduce those 1,000,000 combinations to 1,000 combinations to be tested. That's where AI is powerful. This is just one angle in drug discovery and research. There are many such stories. We can point out to research and references rather than talking about it here. There's a lot of work. I don't think 1 hour we'll be able to talk about where AI is useful in drug discovery. Anything AI is good at, any process where there's a lot of data needed, lot of repetitive stuff to be done, and you have to do it statistically. If you can't do it statistically, then you have to do it by brute force one by one. Then there is a traditional software that always takes a lot of time. AI is good at, improving the productivity of those cases where you have a lot of permutations, combinations, a lot of trials to be done digitally, and you can use statistics or probabilistic mechanisms to control and narrow down the process. AI and machine learning are very good at that. I don't know whether you answered your question, but that's the indication. We can give you some references if you want to specifically look at drug discovery and research.
Thank you so much. Thank you.
Yeah, Professor Anita, you may want to continue.
Yeah, so this is a question from Dr. Satish Kumar on any commercial open source economical application available for a single doctor, small clinic situation. I think that's just the cue that we want to get into our discussion next.
Exactly. There's a related question. Can AI work with only our data? Because I think that the question was longer. They were saying that larger hospitals do research and publish, and therefore they have a lot of data as well. Whereas we don't have data. Can AI work with our own data? Yes, this is feasible. Today, the common thing that is getting deployed in many clinics, if you go with the number of deployments, is the latest thing is the chat GPT. Sorry. A lot of people are deploying chat GPT, but it turns out that ChatGPT can be deployed with a small amount of data as well. There are custom versions of ChatGPT available, which can be trained on data that is available in one clinic, probably over a few months' time, and then you can deploy them. So it is possible AI can be designed and deployed with a small amount of data compared to which is not available in small clinics. I think that's the thrust of the question. The answer is yes. Of course, which AI is safe to deploy today, that's a different issue altogether. So right now, the answer to your question is yes, it is possible to design and deploy AI with small amounts of data, particularly for a single clinic. Yes. Sorry, Professor Anita, go ahead.
Let's go to the next slide.
Yeah.
The discussion slide, maybe you can put it in full screen mode again. Right, so the considerations for transition to AI-enabled clinical practices. So if the question is a discussion, and we'd like for you to share your thoughts in terms of what could your requirements be if you want to transition to an AI-enabled clinic setting, right? So do you have any thoughts on where to start with?
I think, Professor Anita, having the slide and the list of items, then asking questions maybe.
Okay, so we want to move to the next slide?
Yeah.
Okay. Okay, so the first aspect is on the software and deployment itself, right? Are there economical solutions for one-person clinic? Yes, there are several solutions. Some of the ones that we listed in the previous slide in the Indian scenario, those are affordable solutions, and there are several other affordable solutions. But the question is, what is your exact requirement? What are the requirements that you want to satisfy using AI-enabled software, right? And when you have these requirements, what we need to think about first is you're dealing with patient data. Where do we want to store the patient data? How do we want to store the patient data? Do we want to store it within the clinic locally, or do you want to store it inside the cloud, or do you want to give the control of the data that you have, the patient data that you have, to the software that you're procuring, right? So if you're looking at a small time software and they're saying we'll take your data and do some magic with it and give it back, give a result back to it, that's fine. It'll work for us for some time. But then what is it that they're doing with the data? That also needs to be looked at, right? So the questions of privacy, security, and all that comes. So what is it that the software vendor is giving us in terms of data storage? Now, if you want to store the data within the clinic itself, then that means we need to set up the right infrastructure for that. We need to set up the right server, the databases, and all that. And if there is hardware infrastructure in the clinics, then you have to think about the space required, the cooling required, and all that for that, right? So how do you want to deploy the software? What should be the data collection and the availability considerations? Availability in the sense of software availability. How much do we want the software to be available? Do we want it to be available all the time, or can we tolerate disruption? Suppose a server goes down, can we tolerate disruptions? Right. So even in a small application like the patient coming in and registering at the registration desk, they're using a software application for that. The server goes down, then that creates disruption in the sense that entire digitized process will have to move to a handwritten process, right? A manual process. So the queue becomes longer, the patient waiting time becomes longer. So how much availability do we want? Do we want the servers to be available all the time? Or is there a tolerance of non-availability that we can have? But again, that also is linked to how do we deploy the software and what is a vendor giving us, right? So I'm just saying, if somebody is coming to you and saying, okay, we have this piece of software, then these are kind of things that you may want to think about in terms of data, what they store, how they're storing and how they are keeping the data. What is the infrastructure requirement that you will need to take care of? what is the availability that they are promising? Are they promising the software to be available all the time, or are they promising the software to be available only sometime, and so on, right? Now, the other thing is, so right now you identify one particular requirement, and there's a vendor providing a solution for that. Maybe a year down the line, you identify another requirement, and so what do we do with what you have? Maybe there's another piece of software that meets that particular requirement of the new requirement of yours. Do we want a piecemeal solution where there's a first piece of software taking care of the first requirement, and second piece of independent software taking care of the second requirement? And do you want to build your clinic, the roadmap for your clinic that way with piecemeal solutions? Or do we want to choose software such that they are easily integratable with other pieces of software, right? So meeting requirements in a piecemeal manner is one thing, but then while we are identifying requirements for the software to move it to an AI-enabled one, it is also good to be thinking about where we want to be a few years down the line, so that the choice of software, the choice of the AI function in the software can be identified correctly, right? Then there's the other thing of ease of use. How easy is it for us to use the software? Is it the user interface helpful? And what are also the risks when a vendor is approaching you and saying, okay, we have this piece of software. What are the risks involved? Like if suppose 2-3 years down the line, if the vendor goes away, if the software company shuts shop, then where does that leave us, right? Are we logged into that vendor, or can we replace this particular piece of software with something else? What is the support that they will give? If there is a bug, if there's an issue, if the software is not doing what it's supposed to be doing, or if it's doing something wrong, then do we have enough support from the software vendor to be able to mitigate that issue? Right? These are some things that needs to be considered during the choice of software for your requirement. First, you identify the requirements, and then look at the available solutions. But then you also think about each of these solutions from these perspectives. That's the set of considerations that we have in the typical software and deployment side. Do we have any questions in this? So are there commercial, economical, affordable solutions? Yes, there are, but it needs to be thought through on these lines. Right. The second part is on the process side itself, right? How easy is it to adapt a clinic's workflow to the software that we've identified? Do we want to exchange data with other clinics? For example, if you have a clinic which has 3 or 4 centers, then do we want to be able to exchange data with these branches, or the data is localized within each branch separately, right? There may be regulatory or compliance aspects, right? Even though AI does some things, eventually the owner for the decision that is made by the piece of software is not AI. It is not the software. It is the doctors themselves, right? So there may be regulatory compliance aspects, and the other thing is there may also be training required for staff. It's not just for doctors, but the nurses and the administrative staff. People may need to be able to use, people may need to be trained to be able to use the software and the AI. So if the AI is saying something, then how does somebody who's reading whatever the AI is saying interpret that? How can they use the software? These training and the workflow adaptation will also need to be thought of. The last bunch of consideration is not the software or the process, but inherently of the AI technologies themselves, right? So while AI can do magic, it's not something that it's doing on its own. It's trained to do some things. So it has its limitations. For example, if an AI engine is telling us that this particular tumor is cancerous, why is it saying it's cancerous is not something that is still resolved in the AI by the AI community. So the explainability of AI algorithms or the interpretability of AI algorithms is still something that's being worked out. And that's a major concern for application of AI in healthcare. So it's okay for the AI. So in some cases, it's okay for the AI to say, okay, there's something wrong, than it is to say nothing is wrong, right? So a false positive is better than a false negative in the case of healthcare domain. But then explainability and interpretability is something that needs to be considered when we're choosing AI solutions. If the AI software that you're telling that you're choosing is just telling you something, conclusions alone, then you might have to do some work on top of it to be able to have some intervention from you or from the healthcare staff or the nurses in order to be able to augment what the conclusion the AI is telling us. The integration of data from multiple sources is also something that is probably not supported in a unique and not supported in a very well-structured manner. So there are EHRs, right, electronic health records, which talk about what is the structure of data exchange and how data can be used to predict some things and all that. And then there are wearables, devices, and imaging software and all. How to integrate all of this into a single solution, that is not very mature as we understand today. So these are some limitations in terms of in terms of AI, and in general, when you're choosing software or AI-based software to meet your requirements, these are some aspects that we would recommend that you think through before you choose a particular software and jump to adopting it. Shan, you want to add something?
No, I think we should look at questions. I saw one question on the chat. Is there any commercial open source economical application available for a single doctor small clinic situations? The answer is it is not one single thing which will do end to end. And that's probably a tough goal to achieve, that one software for doing all operations of the entire clinic. But yes, today there are solutions available for small clinic or one doctor clinics. EMR Studio, we mentioned in one of the slides, is an example. It's a Hyderabad-based startup, which is basically doing, conversion of handwritten prescriptions automatically to EMR form. And that also has, it also has voice-enabled activation. And so it helps you keep track of patient records and does the speech-to-text conversion automatically. It does handwritten prescription to text conversion automatically. And you can convert all this to digital records automatically. And then it helps you keep track of patients and the digital records. So that's just one example. So you need to look at within your clinic and its workflow. This is why Professor Anita has put in this particular line. If you look at the middle column on process, workflow adaptation. So if you're going to use software and you're going to use AI extensively in your clinic, your workflow will change. So you have to think about your workflow and then ask, where am I putting AI and what software I have to buy? Today, the answer to your question in general is, yes, there are some software pieces, software solutions, but no, there is no one single solution which will take care of everything in your clinic. That's probably 3 to 5 years down the line where you may get solutions where you can just, go to one vendor and buy one software and deploy it, and it'll take care of all the operations in the clinic. I'm saying 3 to 5 years. It's a slightly idealistic scenario. So what is happening today is there are solutions for particular tasks which you want to be automated and use AI in those. Prescriptions is one of the common cases where everybody thinks it will be beneficial. So doctors prefer to write the prescriptions. So you write it in paper and scan it. Then scanning is a process. So instead, people are saying that you write it in these devices, electronic devices, write, not type in the electronic devices. So it's like a Kindle size device, but you write in that. And then it gets digitized and converted to text and then saved in along with EMR. That's one option. The other is you dictate the prescription, orally dictate the prescription in English. That gets converted to text. So this is one particular solution which is available in affordable form. There are companies which are willing to come and set this up as a service to you as well. And there are quite a few companies in that list. In the slide, if you look at Professor Anita had put up, she was talking about iSciences. So there are quite a few companies which are kind of working along with medical devices. Devices that, for instance, which measure your blood pressure or other diagnostic devices. So they're working with those devices. So there is software available. I would say not open source, which is slightly risky in the healthcare scenario because somebody will be and somebody will be responsible for regulatory compliance and all that issues. So therefore, open source is unlikely. In India is kind of notorious for not producing much of open source, but that's a different issue. Right now, open source is not very heavy on healthcare, but affordable solutions are available for single doctor clinics. So that's a short answer. There was one question about antibiotics. I think that question is best left to you rather than me answering how to avoid antibiotics. But
I think basically with all the culture reports and all that, AI will be able to analyze and say where and all we have been using it appropriately. And what I understand is it's basically a lot of input is still required from the medical community.
Exactly. That's the point. So
yeah,
the data, both conceptual data, theoretical data, as well as actual experimental data. What happened to the patients for whom antibiotics were prescribed and long-term impact on the body, those kinds of data has to be fed to AI before it can, predict something.
Yeah. I wanted to know, like, we are using electronic health records. So based on that, EHR, electronic health records, is almost a part of AI.
Sorry, electronic health records are
a part of
நாளைக்கு
AI.
இன்னொரு ஸ்பூன் வேணும். இந்த பையன்
Can
ஸ்பூன்
you
வாங்குது.
mute yourself, please?
Yeah.
No, what I'm asking is electronic health records are presently there. Is there, it's a version of an AI or what is it actually?
No, that is not, that is simply data.
Data.
We simply raw data instead of, say, your prescription, for instance. If a non-medical person looks at your prescription, they may or may not understand which component is what. Right? When I go to doctor, for instance, doctor writes CEO, compliance of. I've gone to enough doctors to understand CEO means compliance of. But it makes sense. You can't keep writing in English. You can't write long English for compliance of any such thing. But so electronic health record says when you store it in digital form, that has to be written in proper structure. Okay, there is a table. In the table, there is a column called compliance of that has multiple rows. You write one symptom in a cell. It's like a spreadsheet. So that is a structured data. The EHR is simply formatting the data in a particular way. So that is essential for doing AI because the data you have to feed to AI first has to be converted to EHR before you can train the data, train the AI on that data.
Yeah, EHR also helps to standardize. It's a standardized format, so it helps
for
to
data
standardize
exchange.
for data exchange. Right? So what the data that you have, like I said, if you have a set of 5 branches, right? If you want to exchange data between the 5 branches, it provides you with a standardized exchange format and a messaging protocol. I think there's HL7 or something, messaging protocol to be able to exchange data. So the intention there is noble in the sense more the data records available, the more accurate models and more useful AI solutions can be built. But the catch there is a lot of data comes from the corporate hospitals, right? How much will they be wanting to share the data that they have with the rest of the world? So not everyone will be wanting to share the data that they have with the rest of the world for business reasons.
Ma'am, can we stop the slide share and then we can ask everybody to mute themselves? Can you mute yourself? Yeah. Thank you. Yes, ma'am. We can go ahead, ma'am.
Yeah, so I was saying how much will the larger hospitals want to share data, more from a business perspective, right? What do they get to gain if they share their data? So those kind of non-technical issues come, and that's the reason why the adoption of EHRs is not as common as as common as it was originally intended to be. Though there are projects across the world, and even in India with the Ayushman Bharat and all, there's it's picking up, but not in the pace at which we thought it would.
Yeah, I understand. But I think as of now, we are in the very primitive stages of application in the clinics and smaller establishments, probably robotic surgeries in those things. And where, in US and UK, there are systematic guidelines are already available. So there, I think the application would be much more than in India, where each clinic is individualized.
Yeah, the software for clinics is something emerging.
Yeah.
And the scale also is being made available on a smaller scale, because AI works typically on a very large scale.
Yeah.
The example I gave was for ChatGPT. ChatGPT is built on the entire data on the web. But today there are solutions which says that if you take one clinic's data for a month or so, then you can train ChatGPT on that.
Okay.
Which means you can now put up something for your patients, to get immediate answers on something based on using ChatGPT kind of software. That's doable. So it's slowly getting there, but even for one clinic, it is not going to be entire end-to-end process in one shot. You're going to get pieces of software, multiple pieces of software. So you have to identify and prioritize what is it you need today. So while everybody will agree is converting these prescriptions to electronic health records is useful, I'm willing to bet there are a sufficient number of clinics for them. That is not the prioritized item.
Yeah, definitely no.
Yeah, so that's what I'm saying. So this is one of the reasons we are talking to you. Find out what is the critical thing for you in terms of requirements. It may vary from clinic to clinic, but if there is some common things, then it's possible for the AI community to provide solutions for those from the research that has already happened. I'm not talking about building new things, but take essentially existing AI and convert it to solutions for clinics. That is feasible today. There's enough things, enough pieces available to provide you a good enough solution, which may not address all your concerns. That's fine, but you have to start somewhere rather than waiting for AI to come and take over the clinic.
Yeah, I think more than what is our requirement, we were all worried from that aspect of how much AI is going to impact our practice.
It is going to, right? The problem today is AI is going to impact all aspects of life. That's a reality. But the question is, in practice, what will happen is, well, always when computers came, also these questions came: is computers going to replace us? No, computers are not going to replace us, but they have improved our productivity in many ways. Yes, it has also provided entertainment, so we're wasting our time. That's fine, but that's okay. That's part of life. Okay, so the same way AI can significantly improve the productivity of doctors and nurses and lab technicians, where a lot of the routine work that they have to do can be reduced. In fact, one of our hypotheses, Professor Anita and I are working on this, is to come up with an argument that if you go to a small clinic where a doctor has to see, let's say 200 patients today, the waiting time for the patient is high, and the productivity of the doctor is low because the doctor has to go through so many patients, and they are not finding time to address each and every patient's questions or engage with them. So our argument is AI can be used to improve that scenario. Patients' waiting time can be reduced. For the doctor, the few minutes they spend with the patients is highly productive, because in the background, AI can take a lot of the patient's data and summarize it for them, do quick things in terms of explaining those.
I think that's the premise that Shan started off with also, where he said AI cannot replace people, particularly in the healthcare domain. It can only help to increase the productivity, make us function better.
Okay. Because there is one thing is in Western countries, probably they don't need the waiting time. But in India, I think the concept of the waiting for the doctor and the doctor also is more, it is about the number of patients waiting in your OPDs makes you a successful doctor.
Exactly, which
So,
I think AI will help reduce that number. So,
but are the doctors looking at reducing the number is the question mark I have.
yes and no, in the sense that I think a lot of patients, a lot of doctors, some of the doctors I know also, after seeing 200 patients, they're exhausted.
They're exhausted, but right now, I think that's not the priority. I think Allalam sir, what do you feel, sir? He was the person who was very interested in.
No, so how to leverage
No.
and exploit that is a different story.
Yes, definitely. Yeah, that's exactly what we are. We don't want to reduce the number. We wanted to increase
not
our
reduce the number. So if you're able to see 20 patients in an hour or 2 hours today, the point is you will be able to see 30 patients in the same time frame later, right? So there may be like this summarized patient records and everything that will help you reduce the time that you need to catch up on the patient's history and all that. So there'll be
that may be a point to look at where we are more when the patient comes in, it has got a digital record. You have a set of questions, and questions can be answered even before we see us, so that the number of patients will increase.
Tracking patients' conditions and the treatment and all of that across multiple visits I think is helpful for everybody, patients, doctors, nurses, because today this is one of the major problems. Even well-literate patients tend to lose records, not able to keep track.
True.
And treatments, sometimes the medicine prescribed is something. When they go to a different doctor, they've lost the prescription. All of this, part of this is tracking issue. I think that can be addressed well.
That can be addressed. Triaging can be addressed.
Yes.
Because we can predict the difficulties.
Triage is where it has been deployed. AI, I think Professor Anita had some cases where triage has been deployed successfully in cases where AI is very helpful.
Because that's one thing for all of us, when there are 200 patients, it's more about missing very difficult cases or very sick cases. So that I think it will be one of the things. And as well as, problems with the dosing, as well as reduction in the pharmaceutical sites, pharmacy sites, reduction in the errors with regard to the staffs, that is one area we are looking at. I think this would be the priority for any clinicians rather than.
Exactly.
Yeah. So do any of them, others people have any questions? I think.
So Dr. Arulalan had something to say. You were asking him to speak.
Yeah, I was just, he was the one who was very much really interested, looking forward to this session. Sir?
He is muted. I'm not able to hear him.
Sir, you're muted, sir. No, he's not muted.
Okay, then he's not connected to the mic.
Sir, you're not able to hear you, sir. So while sir is connecting, is there anybody else who wants to give their inputs or comments or their opinion? Because quite a few of them are using electronic health records and this.
That is good. That's essential and that's good because then there'll be some common format, standardized format data. It's also that I've seen many research projects are going on where smaller clinics and hospitals are pulling up their data.
Yeah.
For achieving scale for AI to be able to train.
Yeah. And one quality index is something which we are looking at, as you said, waiting time reduction, quality of the staff's reduction is something. QI circle is something which we want the AI to come in. Yeah. Okay, Dr. Mani, I think, sir? Yeah, still not able to hear you, sir. You can put it in the chat box, I think.
I think he's not connected to the audio.
My audio, yeah. Dr. Mani?
We put our coordinates in the chat.
Yeah, I saw that. Yeah. I think we'll share it with the group also there.
Sure.
Yeah. Okay. That was, I think, a very good start of discussions on AI for our members, and we'll carry it on from there. So actually, during medical camp, approximately 200 patients how to collect data for the study. I think it's basically, they had a thing from text to voice or something. So you could answer this.
Yeah, so one of the things that is coming up is using multimodal data, which means that as the patient comes in, either the patient talks or the doctor talk, or both of them talk, and that gets recorded and converted to at least EMR, if not EHR. So this is possible today. This is
I was
possible
also.
today. So when you have 200 patients coming in, the time you spend talking, that talking is quick actually. We don't realize as human beings, if you have to type the same information, that's going to take more time than talking. So that data can get, that speech can automatically get converted. And there's one difficulty in India, which is the language issue. Everybody will not speak English. And even in a particular region, if you take Tamil Nadu, I'm sure even in Tamil Nadu, there'll be multiple languages spoken other than English and Tamil when the patients come in. So, but it's possible for all those speech to get converted to medical records and to electronic health records today.
Yeah, if there are no further questions, I think, thank you. I think, Dr. Mani, we can close the session.
Yeah. I think it was an extensive session on AI, and it has a very interesting inputs which has been given to the, because they're given a bird's eye view what AI can do to our practice, what AI can do to our and what we have to look at when you're going to get a software or arrange a AI thing, what needs to be, whether it has to be stored in the cloud. I think they're given a bird's eye view about complete AI. I think they've shared their IDs. We'll share their contact details in our group also, so that if anyone has any doubt, they can discuss or they can send their queries to them. So on
Or
behalf
also
of
participate in the research, I think.
yeah,
Yes, because
we would be glad if you want to get involved.
Yeah, I think Satish has given an idea. Like you can write an article on AI to our Vellore journal. I think that's I think we have a journal which is Vellore, like Vellore journal, where you can write a brief ideas, whatever about this thing AI in a healthcare setup or this thing. We can publish it in our Vellore journal. Okay. So I think on behalf of Vellore, I thank all the three speakers, Dr. Nilofer ma'am for speaking extensively on the shingle vaccine, and Dr. Anita ma'am and Dr. Shan sir for speaking extensively on AI. I also thank all the participants for their time in the afternoon.
Yeah,
so
and that in a weekday. Thank you.
Yeah, weekday. Thank you.
Thank you for having us.
Thank you so much.
Thank you so much.
Bye-bye.
Thanks. Bye.